Hi everyone, my name is Jeff Lee and I'm a periodontist from Toronto, Canada. As a proud faculty member of Bites Institute, I am so honored and privileged to be a part of its 20-year celebration and to present a case on one of my favorite implant topics, the socket shield. Today I will be showing a guided socket shield case and why it should be the new gold standard for the aesthetic anterior implant. My implant journey began after finishing dental school at the University of Pennsylvania School of Dental Medicine. Then I went to the University of Michigan for my periodontal specialty training. And upon graduation, I worked at a periodontal clinic called Perico in Boston, Massachusetts, while also serving as a clinical faculty at Harvard Dental School. 6 years ago, I moved back home to Toronto and currently work mainly at my clinic, Peterborough Periodontics. On the educational side, I am a faculty member at Bites Institute and became a key opinion leader as a MegaGen Midneck Knight 3 years ago. Whenever an implant patient presents to us, we have so many things to document and consider before we can properly diagnose the concern and formulate a treatment plan. This risk assessment process is extensive, with many factors to account for, such as history of the tooth, patient expectations, soft and hard tissue quality and quantity, and many more. This list I present here highlight many important aspects, but is definitely not exhaustive. From my perspective, when assessing a patient for an aesthetic implant, 3 phrases really sum things up. Bone sets the tone, tissue is the issue, and buccal plate sets the fate. Let's keep these 3 statements top of mind throughout the presentation. As with any clinical procedure we do in dentistry, understanding why and having a sound evidence-based approach is very important. It is well documented that we face challenges with bone volume after tooth loss in general, and especially pertaining to a maxillary anterior tooth. The original human study that assessed alveolar dimensional changes after tooth extraction was done by Schropp in 2003 and revealed 50% reduction in bone width in the first 3 months. A more recent systematic review by Van der Weyden showed average bone loss of 3.87 millimeters in width and 1.67 millimeters in height. So right away, we know the level of challenge that we face. Next, we want to know if the aforementioned changes occur in all scenarios or only if the bone remaining is very thin. Boozer's group looked at how clinically relevant these changes were and contrasted the difference between sites with thin bone versus thick bone. He concluded that at 8 weeks, there is a significant difference of over 6 millimeters of bone width loss if the buccal plate was less than 1 millimeter after extraction. To make Boozer's group's finding more relevant, this study by Lindy's group simply looks at the thickness of the buccal plate using CBCT measurements and concluded that in the anterior maxilla, 85% demonstrate a buccal plate thickness of less than 1 millimeter and 50% less than half a millimeter. Basically, that means 85% of maxillary anterior sites will lose an average of 7.5 millimeters of bone width following extraction, which is almost the whole tooth from the buccal to palatal direction. Now, we know how challenging this area of the mouth can be. Finally, another publication by Boozer's group provides a nice summary of treatment protocols and objectives for aesthetic implant sites. The primary objective is to achieve long-term aesthetic outcome with high predictability and low risk of complication for both hard and soft tissues. Secondary objectives include reduced number of surgical interventions, especially open flap procedures, least amount of pain and morbidity for the patient, and the shortest overall treatment and healing time that is also the most cost-effective. Beyond the anatomical challenges, there are several other factors that we face when doing immediate implant therapy, especially in the aesthetic zone. Obviously, we want to minimize trauma during extraction, and there are many techniques to achieve this. Additionally, the implant size and its 3D position is very important for the amount of bone fill between the implant and the buccal plate. Over time, we have learned to position an implant of smaller diameter more towards the palate to maximize the size of this jump gap and to allow for more bone fill. However, is this all enough? For those that have done implants, especially anterior implants, we know that over time this bone will shrink. So is there another modality that can overcome or prevent this? It certainly is a tall order to achieve all of these goals, and that is where the socket shield technique comes in. The socket shield technique has many other names such as the root membrane technique and partial extraction therapy. It is based on the idea of root submergence, which has been around since the 1980s. Specifically, the socket shield concept was first introduced in 2010 by Drs. Herzler and Zur from Germany, and the main idea is to keep a thin buccal portion of the tooth, which maintains the blood supply for both hard and soft tissues. In their proof of principle report, Drs. Herzler and Zur deliberately left a portion of the root during extraction and placed an implant near it. They concluded that this socket shield did not interfere with osseointegration of the implant and therefore may be beneficial in preserving the buccal bone plate. Another group, spearheaded by Miltiades Mitsias and Konstantinos Tsirompras, refers to this method as root membrane technique, and they have also published a lot of initial information and, more recently, plenty of follow-up studies that support the long-term success of this technique. Another industry leader, Dr. Howard Gluckman from South Africa, uses the term partial extraction therapy and also has many publications showing promising results and also detailing the protocol. In this 4-year follow-up study of 128 socket shield cases, he concluded that the technique performs competitively in terms of implant survival rates compared to both conventional immediate and delayed implant placement protocols. Howard Gluckman also has a 2-part publication with lots of detail on the history, indications, contraindications, protocol, and management for partial extraction therapies. In the first part, he notes the different techniques and their indications, as well as some contraindications such as active periodontitis and mobility of the root fragment. A third relatively controversial contraindication is external resorption. In the second part of his publication, he highlights the procedure itself and possible complications. The most common complication is exposure of the shield, which can be either internal or external. Usually, this is resolved relatively easily. However, some severe complications may necessitate the removal of the shield or loss of implant, but these are very rare. I highly recommend you read these 2 articles from the International Journal of Periodontics and Restorative Dentistry to get a comprehensive understanding of partial extraction therapy. When it comes to executing the socket shield technique, there are several kits available, but I prefer the partial extraction therapy kit by Megagen, and this video will demonstrate its use. First, you want to measure the root length on the CBCT to determine where to place the stopper on the number 1 drill, and then use it to drill through the root canal space to the apex. Then, the number 2 drill is used to split the root, making sure that you extend the full length of the root going in a mesial distal direction. The palatal fragment is then carefully removed, and the number 3 round burr are used to reduce the buccal shield to the desired thickness. Next, the number 4 burr is used to smooth the internal portion of the root all the way down to the apex, as seen here. After that, the number 3 round burrs are used as well as the number 5 burr to reduce the crustal portion of the root down to the level of the bone. This is very important so that we are not leaving a piece of the root at the tissue level. Finally, the number 6 burr is used to make a chamfer margin, allowing extra space for the restoration and the bone graft. Once the socket shield is prepared, regular implant drilling and placement is done, and bone graft can be placed along with a customized provisional. Now, let me introduce my patient, who is a 60-year-old male with a fractured 2-1. This patient has had this crown, which has an obvious color mismatch and a size discrepancy from the 1-1 for a long time. Perhaps his aesthetic demand isn't the highest, but he does have a high smile line, and therefore this is still a challenging aesthetic case. The intraoral picture shows chronic marginal inflammation due to the multiple times that the crown has been re-cemented. There's also slight recession compared to the 1-1. The PA shows a root broken at the gum line and a short root canal treatment. The CBCT slices confirm the short root canal treatment and blunting of the root apex, and there is a significant void between the crown post complex and the remaining root. This buccal plate has decent thickness, and there is plenty of apical bone into which we can anchor our immediate implant. This is a great case for a socket shield. The occlusal view shows some moderate crowding, especially with the 2-2, and some slight incisal wear as well. Note the buccal gingival contour preoperatively as well. So the first step of the socket shield is to remove the crown. In this case, it was already loose, so this removal was simple. In other situations, the crown can be sectioned from the root. Note here the irritated marginal tissue on the buccal and extending to the distal aspect. So after the crown is removed, the number 1 drill is used with its stopper to drill through the root apex of the root. This distance should be measured on the pre-op CBCT. The next step is to use the number 2 drill to split the root in a mesial-distal direction. I try to do this in a semi-lunar shape to try to keep some interproximal root structure to help maintain the ever-important interproximal bone. Once the 2 fragments are separated, a narrow proximator or elevator can be used to remove the palatal fragment carefully. This should be done without putting any pressure on the buccal fragment, and the instrument should never be placed in between the buccal and palatal pieces. After the palatal portion is removed, the buccal fragment should be checked for any mobility. If there is mobility, then unfortunately the shield has to be removed. So this is what the root looks like after the palatal fragment is removed. And now it is time to start shaping it into a proper socket shield. So here we use the number 3 round burrs to reduce the shield to the desired thickness throughout the whole length of the root, and then the number 4 drill is used to smooth the internal portion of the root. Finally, number 5 and 6 drills are used to reduce the crustal portion to the level of the bone to create a small chamfer for extra restorative space. Here you can see the root has been reduced to the proper size and dimensions, and for this case a MegaGen R2 gate guide was fabricated to facilitate fully guided implant placement. After the initial drilling to depth is made, the drill is used to take a PA for visual inspection of the correct placement and alignment. And once osteotomy is completed, a special driver with colored markers is used to place the implant to ensure correct depth and timing of the internal hex. Generally, the implant should be placed away from the socket shield to avoid moving the shield at all, and adequate initial torque is required for provisional fabrication. A 4x4 healing abutment is used to seal the implant, while allograft sticky bone is used to fill the jump gap. A chairside provisional was made from acrylic as I was unable to use his PFM crown. The screw retained provisional is inserted and kept out of occlusion, and a small PRF poncho is also placed, and a PA is taken to confirm seating and angulation position of the implant, and this is how the patient leaves the clinic on the day of the surgery. At 4 weeks, the area is healing very well. Note the color and contour of the peri-implant tissue. It is much healthier now, and even some coronal migration has occurred. The occlusal view shows the contour has been maintained very well at this early stage. After 3 months of healing, a PA is taken to confirm the healing. The tissues look very healthy and stable at this point. And the occlusal view again shows good healing and contour maintenance. So at this time, a customized impression coping is fabricated using the provisional and then used to make a final impression. A final screw-retained ceramic crown was made, and here's how he looked at crown delivery as noted by some slight blanching of the surrounding tissues. At 3 weeks after insertion, some photos were taken along with a PA to confirm healing. The patient was very satisfied with his result. And here he is after 16 months, with a new PA to confirm things are unchanged radiographically. There's a very minor amount of recession that has occurred, likely related to the bulk of the crown at the marginal area. But overall, this result is excellent for a happy patient. Also at 16 months, we can see the occlusal view shows great buccal contour maintenance and up for a year and a half. And here he is, his before and after. So as you can see, the socket shield technique is truly predictable and promising. It is a remarkable technique that overcomes the many challenges we face with an anterior aesthetic implant. It prevents the collapse of the buccal plate, eliminates the need for adjunctive gum grafting most of the time, helps provide implant placement towards the palate, and it is the ultimate preservation of biology for implant dentistry. In the past 5 years, multiple publications have come out, many in the form of systematic reviews and meta-analyses demonstrating the effectiveness and success rate of the socket shield technique. Even still, while this is all very promising, more research is required, especially in the form of larger, multi-centered prospective studies. With advancements in digital dentistry, guided socket shield preparation is also something in the works and is starting to be done, as well as using partial extraction therapy for full arch cases and alongside dynamic navigation. There is so much more to this technique and its various applications, and I have really only shown you the tip of the iceberg in this presentation. Thank you so much for your attention, and I hope you were able to take something meaningful away from this quick presentation. If you have been an active member of Bytes Institute, we thank you for your continued support. If you are new to Bytes, we welcome you and are looking forward to seeing you at future courses. A great way to get in touch with us is through our Facebook group, Bytes Global Implant Network, or Begin. And if you have any questions, please don't hesitate to get in touch with me through email or Instagram. Until then, all the best. Thank you.